I can see Zoe's there. Everybody else got their cameras off. So, hello, Zoe.
Hello.
I can see we've got quite a few people already. Just to explain to everybody, we are recording this session because we've got a lot of our fellows, that sounds quirky, who are of course on holidays at the moment, etc. So they're not going to be able to join us today. So we are recording. I hope that's okay with everybody. We are having some technical issues. We don't appear to be able to get breakout spaces today. Breakout rooms working, so we're going to try something a little bit different. And just to let everybody know, we don't have a CPD session next month. You all get August off, a little bit of a break from us. But we have already put the invite out saying if any of you wanted to get together and join up face to face, go for a walk, something like that, you could use the day, the afternoon, and you're more than welcome to do that. What other announcements have we got for the gang? We're starting again in September with these sessions. I think you've all had the new calendar of events for next year, and they're being updated as we go forward. And today we're going to do our usual ideas board at the start and the end of the session, and we're going to actually do our survey on something called Mentimeter. And make it a little bit more interactive and live at this session, and hope you will join in with that. Okay, so do we want to kick off with you, Lee, to start with?
Thanks, Mary. Yes, welcome everyone. I think we've got starting to get more numbers joining. I hope you're keeping well. As Mary said, we're not able to do breakout rooms at the start of this session, technical difficulties. So I'm just going to put the ideas board, your ideas board from the last learning sets from the Shapes Influencing Without Hierarchy session back in June last month. So similar to last time, if you can just click on the link and bring up the ideas board in another window. What I'd like you to do for the next 5 minutes or so is just put down a post-it note in question 3, which is a bit of reflection about what you may have done differently as a result of that session. So if you can all just click on the ideas board link, you'll see the ideas board from last month. If anyone wants to share and verbalise as they type, that's fine as well. Just do unmute yourselves and you can take it in turns to talk about what you're putting down as well. If not, I'll start reading a few out.
Lee, for some reason I can't see the link. Did you put it in the chat?
Yes, I've put it in the chat. Can everyone else see the link?
Yeah.
Yeah, I can.
Was it working? Great. Can you see your meeting chat, Rebecca? I
can, yeah. Nothing has popped up for me for some reason.
I'll put it in one more time and maybe it'll...
Don't worry. As I was there, it's not so important.
Worst case, Lee, you can always share your screen.
So who's going to be first to put their post-it note board up? So if you can remember back to the shape session, we introduced a few models, the scarf model and with the zone of power as well, and the influence model. And the idea about currencies as well. I find that quite interesting in negotiating as well. Did any of you end up having conversations within your practice or PCNs? So great. The first post-it note board. Better negotiating for training and teaching opportunities. Does anyone want to elaborate on that? How did that take place, and
Everyone's going to have to talk a bit more this week because we don't have the breakout spaces.
Second comment was spend time before any potential influencing discussion. Understand what I actually want to get out of it. Yes, thinking around before taking a step forward. I've used the techniques from the session to negotiate an issue which I felt was going to be challenging within my practice. That's great to hear as well. So think about the approach. Being able to negotiate safe working in my third trimester by collaborating with the practice manager with ideas on how to handle this. That's really good, and I like the word collaborating in this. So hopefully with negotiations, it's about finding a win-win for both sides and perhaps a middle ground as well. Appointment system. So yeah, that was quite topical last month, wasn't it? Finding values about what we want to achieve as a group before deciding on action plans. Also exploring my own currencies, motivators, particularly when thinking about potential new roles. So yes, that's especially important in new environments, and actually think about what currencies and motivators there are within systems and new teams as well.
Does anybody feel brave enough to speak up about any of the techniques that they might have tried out from last week's session?
Sounds like a no.
I can expand on the appointment system one.
Oh, brilliant.
Thanks, Emma.
Is my mic working?
Yes.
So I really liked what she said about finding the common ground first and finding what I think it was. She went through like the different levels of kind of what it came down to in terms of decision making and what everybody wants. So we had a meeting about our appointment system, and so actually it was really helpful to start off by saying what are the ultimate aims we want to achieve. So we thought of things like we want it to be safe for GPs, we want the workload to be reasonable, we want the best access for patients, and we want patients to be able to access the most appropriate clinician or pharmacist or whoever. So it was really helpful to start with those values first before then kind of coming at it with difficulties, if that made sense. So it was almost agreeing the common ground of the end goal before then coming up with those practical solutions. So it almost brought everyone onto the same playing field, if you like, before we then went on to different ideas about how we could change the appointment system. So finding that common ground. And I think then it just creates that environment where everyone realizes that actually they want the same things before you then go into negotiating different ways of doing it.
And that's really powerful, isn't it, Emma? It's easy to get stuck into the small details without actually taking a step back and think about the foundations and the basics, and she said finding the common starting points, and it takes a bit of work getting back to that common starting point, doesn't it? But it's well worth it, because then you can build hopefully together collaboratively from there. So that's great to hear. Was there anyone else who wanted to share that? I think it's really helpful hearing from you individually about your experiences, and that's what we're hoping to get out of these sessions as well.
I've had a fairly similar experience to Emma, but on a slightly different perspective. So We've had similar challenges with appointments. We're really struggling to have enough, probably like every surgery. And I think I was of the opinion that my perspective or opinion was vastly different to some other people in the practice. And then I kind of thought through what I know about those other people and what my values are and what their values are. And it was actually really helpful to realise that all of our values are the same or very similar. And as Emma said, to be able to then talk to those people about the things that are difficult, starting from a point of knowing we have a shared value, just because we think the solution is something subtly different, that it's not a problem, and it's easier to go into it when you know that you all have shared values, exactly as Emma said. So I found being reminded of that as the starting point really helpful.
That's good to hear, man. It builds team working, doesn't it? It's a nice feeling to feel like you've got a common goal and you're working together. And actually, it's good. I think we can all appreciate different perspectives and ways of finding solutions around problems, but sometimes that's the surface of what we see and are presented with if we don't have further conversations. So thanks for that, Emma, as well. Just have a quick look at the board. Great. There's something about possibly having boundaries as well with partner, being clear where my red lines are. Good.
So I think we've got something a bit different now to share with you. Miriam, have you got the Mentimeter page up?
I do. Just give me a second and I'll put that through. So just let me know when you can see my screen.
Yeah, yeah.
Screen.
Yeah.
Okay, so we're going to ask this question quickly, and you should be able to, if you, I don't know if anybody's brought up the menti.com website, and you can use the code on the top of the screen there when you log in, and then you can actually answer the first question at the moment, and we can see how confident you're feeling about the project we're going to start talking about today for year 2. Hopefully this will, oh yes, there we are.
Perfect.
And as you submit, we're starting to see how many people feel confident, not confident, average. Ooh. I think it's a bit of a race for not at all confident, which isn't surprising because we haven't done the session yet. I thought we'd do this because it's a bit more interactive. It's a bit different to our usual survey, and we're going to have a very similar screen, etc., towards the end as well. So capture your thoughts after the session and how you're feeling about it. I don't know if anybody's managed to submit yet or not, because we can't see the count on there. We can have 14.
Yeah.
You can see the count at the bottom.
In the bottom right, yeah. Good eyesight, Mary.
Got my glasses on today. I think we're almost there with everybody having answered, so you can keep submitting. Okay, so I think we all know that we're not very confident about our projects yet, and I think that leads us nicely into David and his session. So I don't know if you want to unshare now, Miriam.
Okay.
And we'll hand over to David.
Thanks, David.
Hello. I've just realised my camera's on the wrong screen. Hang on. So I'm in the surgery state. Hopefully you can all hear me.
Yeah.
Good.
Yep.
Okay, great. And I'm also going to try to. I've got 2 different computers and 3 different screens going, so I might get a bit confused. So I'm going to try and share my slides from another computer so I can still see what people are doing. So the first question I want to ask is, can you put your hand up using Teams if you weren't at my first session? Just so I've got a sense. So if you use the Teams function, you click on the three. There's a little hand and a face, and you just click on there. So I can see 3 of you, I think, two or three. Yeah. Someone's putting their hand up and down like a sort of raver. Okay, so apologies to you. So I'm not going to. I will be doing a little bit of a recap, but it might go quite fast. Okay, some of this stuff you'll have heard before. If there is stuff that's difficult, so I'm going to really encourage you to stick stuff in the chat box if you've got questions. Okay, very happy to stop, pause, reflect. It's very likely if you've got a question, other people will be thinking the same thing. So don't hesitate to ask questions. Okay, so I'm going to just duck down out of sight for a second and try and get some slides up on my other laptop. So sorry about this. So what I want you to do first, actually, I was going to do a Menti, but I've run out of time, so I'm going to do it on the chat box. I just want you to stick in the chat box, how would you approach, in a sort of series of maybe 5 or 6 bullet points, how would you approach a quality improvement project? Okay, so some of you have started already, but what are the key themes that come up for you? So just to give you a sort of context for that, it would be, what would be your first step, your second step, your third step? And if I'm not going to give you context, it will give the answers away. So that's all you need, about 1 minute to think of it, and then stick it in the chat box, and we'll just see what people come up with, and then we'll recap what we did last time, and hopefully there'll be some overlap. Rachel, you're the winner. First person to answer. Well done. Doesn't matter what you said. Speed is everything. Any advances? I need 2 answers before I can move on. Well done, Hannah. Okay, some good stuff coming through. I'll give you another 30 seconds and then we will recap from last time. Okay, so I'm going to start with you, Rachel. You were first to reply, so thanks for that. And really good. So, so what you've called baseline is interesting. In a way, the baseline is the current state. So it's a sort of crossover. Numbers 1 and 2. I think you're absolutely right. We need to understand what's going on, and does this actually matter? Is this really a problem? Okay, and it's very common actually for us to try and fix things that aren't really problems, or at least not significant enough probably that we should be spending a load of time on them. So does it matter? What exactly is going on at the moment? So we need baseline data that we can work on. Okay, set an aim. Okay, so we talked a bit about aims. We're going to just explore that a little bit more today. Okay, generate ideas for change. Yep. Test those changes. So that's basically what we talked about last time. And then other people have put in. So I think Hannah, you mentioned ways to measure the problem. So that kind of comes in after setting the aim, before we generate ideas, is how we're going to know if it's got better. So that's good. And then some people mentioned the fishbone analysis or the tree diagram. It's a pretty sick looking tree, I have to say, Zoe, but you remembered it, so that's what matters. So fishbone analysis was sort of probably at 2, I would say. Understanding the current state. It's a root cause analysis tool, fishbone. So it's about saying, so why have we got this problem? What's actually going on? Because it helps you then decide what you want to fix. If you don't like the fishbone diagram, then process mapping is another very good way of doing that. And I haven't planned to do process mapping today. I've got so many things to do. I don't think we did discuss process mapping last time, but we could discuss it briefly and I can explain it if that's helpful. And were there any others? So we've got, so Emma, you mentioned at the end, re-audit, review changes and outcome. So oh, here we go. And is it FOPE? Don't know how you say your name, sorry, but rerun and see the impact that's happened. Rinse and repeat. Yeah, so rinse and repeat is these PDSA cycles. So this is how we test whether the changes we're making are working. And the PDSA is about testing. Each time we want to make a change, we keep testing at small scale to see what works before we then implement across a whole practice or across a series of practices. So it's about testing. It's a test of change and how to change as much as anything. And early on, you won't be getting major data. You'll be getting kind of early qualitative data. So let's just look at these slides. This will summarize going back what we did. So we talked about this fishbone analysis. Okay. And if you imagine we start with a blank one of these with just the boxes filled, the headings stay the same, and the right hand box is the problem that we've discovered. Okay, and then we'll, under each of the sort of the bigger spines, these people, process, measurement, equipment, environment, we then brainstorm, what do we think are the causes? What are the causes under people? What are people doing that is causing this problem, if that makes sense? So really useful tool, very simple. And obviously, the implications of it are that we then try and fix whichever of these seem to be the most important root causes. But why this is particularly important is we have to remember that it's very rare that there's one problem. Okay, there will be a mixture of causes. Okay, the other thing I'll mention is that which I forgot to respond to in. Who put this in? I can't remember. Someone saying about, you know, I'd want to, here we go, Zoe, I'd want to be asking the team, are they keen for the subject to be addressed? Very important point. So we can stick our problem in our right hand box here, but actually it might well be worth doing a little bit of stakeholder engagement at this point. You know, is this something that actually matters to folk? Because if you do all that work and then they kind of say, well, actually, I don't care, I'm not changing, then you haven't got very far. So let's move on next. So remember this model for improvement. So this is essentially what you wrote in your boxes. So what are we trying to accomplish? What's the problem? Okay. And remember that the fishbone is to help us work this out. So what's the actual problem we're trying to fix? And it will probably be one or two of those smaller boxes on the, or smaller spines on the fishbone that we try to fix in turn. Okay. How will we know that a change is an improvement? So the first bit is the aim. The second bit is the measure. How are we going to measure this? Because if you don't measure it, you'll never know if it's improved. Okay, so what are we going to measure? I'll talk a bit more about measures later on because I've got some more sort of tips for you on that. And then what change? So this is the ideas generation. What are we actually going to change? And again, there's not going to be one thing. There's going to be, you know, a handful, or maybe a very, very large handful, maybe a whole sack full of ideas that you come up with. And I've got a couple of tools for later that we can use to try and improve the quality of our ideas generation. Okay, so the more ideas we have, the more chance we have of getting what you might call the right idea or the best idea. And then we have to test them. Okay, because you've got your idea, you think, ah, brilliant, I've got this fantastic theory that if I, you know, change the color of this form, suddenly everyone will fill it in. Well, how do you know? Well, you're not going to know unless you test it. And if you change it across the entire practice, for example, you go to a load of effort, you make it, it's usually effort for you, probably effort for other people. You're asking people to change their behavior. Okay, that comes at a cost. They're not going to do it kind of, well, there's a limited amount of goodwill for behavior change. Okay, so if you just drop it in and it doesn't work, you're taking some of that currency away. You're using up some of that goodwill. So we test at small scale first, and that's what Plan, Do, Study, Act is about, and that's what we practiced in our coin spinning exercise last time. Okay, so test it with one person for one patient or for 1 hour first. Get your feedback. What happened? How can we make it better? Let's change the form. Let's change the process. Let's do it slightly differently, make it better. Test it with another person. Test it with a group of people. Test it for a bit longer. And you do multiple of these cycles before you want to drop your whole change into the system. So hopefully this is all making sense. There's a little bit of jargon in this, and I think that's a problem with quality improvement. Actually, there's too much jargon. I'm trying to keep my language free of it, but I slip into it all the time, so I apologise for that.
David, I'm
hello.
Just going to ask quickly as Mary. Emma Root, you've got your hand up. Is that a legacy hand, or have you got a question for David? Oh, hand's gone down.
Guessing it was a legacy.
Yeah,
a legacy hand. So there's a phrase that we didn't hear before the pandemic. Legacy hands. Okay, so then we talked about generating ideas. Okay, and if you remember, this was about we talked about how you could do this virtually with literally squares in PowerPoint or on any of the sort of whiteboard type softwares, and then you can move them around and group them together, and then you can prioritize them. So we talked about prioritizing with a matrix like this, and obviously we tend to do the things that are going to have a big impact and be easy to do. So the top right will be our first port of call. Okay, so that's a really simple tool. It's it's not hard science. You're talking about people's sort of opinion on what's likely to have the most impact. You can obviously use the evidence where it's there. So where there is strong evidence of what works, go for that for sure. But often when we're changing stuff in our practice systems, there won't be evidence. Actually, there won't be a simple kind of, there won't be a study that says to you, this is the best thing for a 17,000 patient practice in suburban Oxford, because no one knows until you've tried it in your own specific environment. So there is a bit of not guesswork, but how do I describe it? Yeah, it's well, you've got to test it. That's the thing. You're going to test it. So and this was then going back to PDSA cycles, and you remember we tried that with spinning the coin, tweaking each time, one thing at a time. Let's test the next thing. Let's test the next thing. Let's test the next thing. But each time, the point about the P of PDSA is you're planning your test. So we want to, we're going to try spinning left-handed. Well, let's plan how we're going to do that. Who's going to do it? How long for? Where are they going to do it? When? How are we going to test? How are we going to take our data points? Now, that was a little bit contrived in something as simple as a spinning a coin example, because you're doing much the same thing each time, but you might be making quite big changes. And that planning of the test, so planning means, the details of the actual testing process, how long for, who, when, where, those questions. Okay, if that makes sense. So, and as I said already, so this is basically what I've said, test early and test and tweak and test and tweak. Rinse and repeat, as Fopo's put. So here we go. I'm going to talk a little bit today about, to start with, about aim setting. Okay, and so there are lots of kind of traps in trying to do improvement work. Okay, and a classic trap is that we start, I mentioned this last time, was we start at question 3 here, the change that we think will result in an improvement. So it's particularly bad with GPs because we're all incredibly solution focused. So we all just want to help, we're desperate to help, we've got loads of ideas, really clever, And it's the same, you know, all across healthcare. You just find all these clever people who've got loads of knowledge about the system. You know, they've worked in it, and they say, I know what to do. I know what to do. And usually, in my experience, the worst person for this is the senior partner, although not in my practice, I should say, because Rebecca and Lee are here, so I can't. Don't tell Joe. But essentially, if you start with the solution, you know, you're missing out on all those possible opportunities from the ideas generation. Okay, so you're going straight in, and obviously it's often we don't even test. So, and a classic thing is, you know, the practice. I've got this friend in another practice, and they're doing X, so we should do X as well. You know, pharmacists, physios. In fact, what's interesting about it is that so much of what comes out of the centre, so you know, national policy, is exactly like this. So I spent the last 5 years or so working for NHS England, teaching people how to do quality improvement. And actually, we would often get these things say, right, you've got to go in and help these people because they need to get pharmacists into their practice. That's not really quality improvement. That is implementation of a national policy. It's workforce redesign. Sure, you can change the way the pharmacist works. There's lots you can do to make it really much more effective. It's not a true quality improvement. The best you can do is say, okay, what problem would we like our pharmacist to help us fix? And then you can sort of go through these questions, but it's a little bit of a moot point because you know what your solution is. We're implementing a pharmacist. We're employing a pharmacist. Anyway, a little bit of a sidetrack there. The key point is if we try to start up at the top, so we know what we're trying to fix, even if we have a vague idea what we think we want to do, we'll get better solutions. Okay, so, oops. Yeah, there we go. So again, classic. I've got this idea. I think it's going to work. I'm the senior partner. Let's do it. Well, you know, what is the actual problem? Okay, so you might say, and this is an example, let's get a physio. Well, actually, have you looked at the data? You know, what is it telling you? Have you got high numbers of MSK consultations? Are they continually coming back? Because if they're not, then maybe you're dealing with them perfectly well. Is it a problem that people care about? Or is it something that people say, actually, I'm not bothered. I like MSK. So you know, what exactly is the problem you're trying to solve? Okay, and who else could you ask? You know, so what do the patients tell you? Okay, what do the staff tell you? What do third parties tell you? Where else could you get your data from? So what does the prescribing data for your practice tell you? This patient survey, you know, what are you looking for essentially? If you've clocked a problem, so supposing, I don't know, you think there's a problem with prescribing data, we're prescribing too many broad spectrum antibiotics. I can't remember who mentioned at the start, you know, baseline data. What does the data actually say? Is it really a problem? So look for that, okay? And just ask people, you know, because you'll find something really, really worthwhile by doing that generally. Okay, so let's move on. And this is just to reiterate this point. We're going to come back to measurement. But if you've got a problem and you can't think how to measure it, I'd be very, very wary of going into a quality improvement project on that, because you'll end up doing a load of work, but you'll never really know if it got better. It can be okay, of course, to measure patient satisfaction, for example, or even staff satisfaction. Those are measures, and they may well be a perfectly valid aim for your project. But if you've got no measure, you're really in a lot of trouble. Okay, and also no one will ever commission it from you. So things don't tend to sustain if you don't have good measures. We'll come back to it. Oh, wrong screen. And then, and only then, do you start looking for the ideas, which is what we discussed last time. So remember, we probably did discuss SMARTer last time, but even if we didn't, I can't imagine any of you haven't had SMART aims rammed down your throat for the entirety of your career. Two other things so this is SMARTer, which is what's a sort of augmented version of SMART. And we sort of talked earlier, didn't we, about if no one cares about this, not much point doing it. Okay, so the E of engaging is really important. And I think I also mentioned to you last time that one of the biggest weaknesses in improvement projects is people don't write stuff down. So they do their PDSA cycles, but they don't record them, and they might record the data, but they don't actually ever really write it up, and it's all just kept on a spreadsheet somewhere. And so these two things, engaging and recorded, are really related, actually, because if you want to engage folk, then a little bit of data and showing them that things are getting better is incredibly powerful. But the other problem is that if you then want to go back and say, well, what worked, you won't have any idea unless you've recorded it. Okay, so you've got to try and write stuff down as you go. So smarter aims, pretty straightforward, right? I can't, if anyone's got any questions about smarter, then do shout, but I imagine you've all heard it many times before. So I'm going to just talk to you now. Oh, this slide, there we go. About the common problems that I see, or we see, when people are writing aim statements. Okay, so I've written you two classic aim statements that I might see from people who want to make a change in practice, or they've got a problem. Okay, so they've seen a problem with musculoskeletal. It's too much work. We want to make our lives better. So, Mary, did we get any breakouts in the end, or are we going individuals today?
We're having to go individuals, I'm afraid, David.
Okay, so what I need you to do, guys, I want you to spend about 3 minutes now, just with a paper and pen, look at those aim statements, and this is your chance to give me real full-bore criticism. Okay, you can't hurt my feelings. So what's bad about these aim statements? You can tell me what's good as well if you like. Okay, but obviously I've put some errors in here, so I'm interested in what you think is wrong. Okay, and you've got 3 minutes to have a quick think about it, and while you're doing that, maybe have a think about what might look better as well. Okay. And obviously we'll stick them in the chat box when we're ready.
Should people start to type in to the chat box the things that they think are wrong?
Go for it. Go for it.
Let's start to see some.
See how many you can get. Bear in mind, these are two completely separate things, but they cover most of the big mistakes.
Yeah, we've got things coming through now.
Yeah, I can see some good answers coming. I'm going to give you another minute to write some answers so that we get a good range, and then I'll try and Okay, so we've got some good answers here. So essentially, I mean, there's loads to pick out. So who is we? Yeah, I mean, you have to define that, obviously. Hopefully the people who wrote it knew who they were. If not, therapy is available. So what is the best MSK care? Absolutely right. It's incredibly vague, isn't it? And someone else, why in the locality? Why are we comparing to locality? Good question. You know, I think we're often given targets. We're often, you know, you look at any prescribing report and you're always compared with every other practice. Where's the good place to be? Is it bang in the middle so you don't cause any fuss? Do you want to be the best? Well, what is the best, you know, antibiotic prescribing rate, or the worst? You know, so these things are quite complicated. So define best. Very, very good point. Someone's not time bounded. So, you know, what, by when? The best care by when? You know, what does that mean to us? So essentially the first statement, okay, I've seen this before. Okay, so this is based on reality. It's surprising how often people write this sort of thing. This is a mission statement. Okay, perfectly reasonable. We want to provide the best care in the locality. Fair enough. Go for it. What does it mean? So if you're actually using it as a motivator for your team or something like that, well, you know, it might be reasonable. If you're using it as an aim statement for a change project, I would say not reasonable, because you'll never know when you've got there, and you haven't said where, when, and you haven't, you know, it's nothing specific about it. So absolutely right. Okay. Solution to aim statement 2. So a few people have spotted the key problem here. Okay, so this one's a little bit better. Okay, reducing MSK presentations to GPs is a little bit more specific. It's still a bit vague. I think it was Emma said, well, what if that's not a problem anyway? And it's a good question. The key problem is, so they've put a time in. Okay, so that's good, isn't it? But we've got the solution in the aim statement. So this is the other really, really common mistake that people make. Okay, so they almost do their thinking in advance. They come up with their ideas, and they then put the solution in. So they've already moved themselves down the line. They're basically doing what we said at the start, which is, although they've created an aim statement, so they've started at the top of the model for improvement, the first of the 3 questions, they've taken us straight down to the 3rd question. Okay, so it's not clear how measurable that is, although it sounds like it's probably going to be measurable in some way, but they've already gone to their solution. And is that the right solution? Really, really good question. Don't know. Okay, so we haven't done our options. So there are other mistakes, but those are, I think, the 2 commonest. Okay, so one is like the kind of classic mission statement. It's wishy-washy. You can't disagree with it. Why would you not want to provide the best care in localities? It's the sort of thing when people say, you know, we want to provide safe, high quality care for all or something. Well, great. What does it mean? Okay. And then the second one is this idea of accidentally sticking your solution in, because it also ties you to it then. You've already said physio is the solution. So can you now, for the next 2 minutes, write me an aim statement for a practice that has decided that their musculoskeletal care is a problem, and the main problem is that the GPs are overwhelmed with MSK care that are sort of relatively simple conditions, and they've seen a high follow-up rate, so patients coming back repeatedly. So they want to improve their musculoskeletal care based on those findings. Okay, high rates in comparison to national rates and high follow-up rate. Okay, and I want you to write me an aim statement that is smarter. Okay, and I'll give you 2 minutes, and then stick them in the box, and I'll be very gentle, and we'll just find a really nice one and look at that. And if I criticize you, you know, I don't take it personally. Okay, feel free to stick them in the chat box when you're ready. Okay, a couple of good ones gone in. Okay, so I can't critique any of these. They're all great. Okay, so fundamentally, what we tend to find is that aim statements will usually have either increase or decrease something, because we've said there's a problem, so we'll either increase or decrease it. I guess the only other solution would be to ensure that something happens every time or something never happens. So you might say, this is so important, this is an error, must never happen, so we're going to track this, or we want kind of 100% achievement of X. Okay, not that many things that are amenable to that, of course. So usually it's up or down. Okay, and so we've got it's specific, so you know, various different ones, but well, let's go to the start. So Emma, you were first. So reduce follow-up appointments by 50% for patients presenting with MSK problems by August 22. So that is specific, it's measurable. Is it achievable? Well, that's an interesting question. You know, is it relevant? Yes, it sounds relevant to the problem. Is it time bound? Yes. Is it engaging? It depends on obviously who you're talking to, but you know, to most GPs that would be pretty engaging. And obviously the recorded bit is you've written it down, so that's good. The interesting, so the question here, so we've got this reduced follow-up appointments. There is still a little bit of ambiguity in what is a follow-up appointment. So, and how easy is that going to be to measure? So I did push you in that direction, and my own aim statement is very similar to this. So that might be quite hard to measure. So we just need to be aware of that. Okay. Emma, yours is slightly different. Weekly average number of initial and follow-up MSK presentations. So that sounds like it could just be MSK presentations, full stop. We might want to measure both, or we might, you know, you've covered everything there. But yeah, it might be easier to measure that actually, because that's something that we could potentially, we don't have to divide up so much. We don't have to define follow-up in the same way. So you're not wrong, Emma, at all. In fact, I pushed you in that direction, but it might be fiddly. Emma, I like this, so within 10% of the national average. So just to sort of out an elephant in the room, okay? So some people are very anti-targets, okay? Just quickly, I'll just take a free-for-all. Why are targets potentially a bad thing? Just feel free to chat out into the open. I haven't heard anyone speak for ages. I'm getting really lonely.
I suppose if you're thinking about a target for MSK referrals, reducing it by a certain percentage is not necessarily a good thing if they're all appropriate referrals. So I guess, you know, and follow-ups are potentially appropriate as well. So you're at risk of achieving something that's not necessarily in the best interests of the people you're trying to help, I guess.
Yeah, I agree with that. So that kind of comes back to our point at the start of how do we know this is a problem? Absolutely. Any other issues with targets?
They don't necessarily take into account like your local population, so it's quite a generic target maybe for like the whole country, and actually it varies. The thing about general practice is that everyone's practice population varies substantially, so you don't want to set yourself up against a target that's for a population that's very different to the one that you're working in.
Great point. So it's exactly what GPs always say whenever a commissioning group or NHS thing ever say to them that they need to get better at something. We're different, but it's true. I mean, isn't it? So how do you know what's right for you, what's right for your group? So I'm not saying you're wrong, Emma, but it's interesting, isn't it? So what is the right amount? How do we know? So one other problem with targets in particular, anyone else got any thoughts? So the number one thing is that they get gamed. Okay, so we put a target in, and then of course we all try and get to that target, and we'll find any sort of sneaky workarounds we can to get to it, but actually it doesn't actually improve the quality of the care, or we find different ways of measuring stuff, so we define it differently. The other thing is, so fundamentally, what is the right answer? Well, it's almost impossible to say. General practice is so complicated, or even complex, frankly, that what is the right number of MSK presentations? Well, it depends, because it depends how you define an MSK presentation and how you record it, and it depends on where your practice is and what your practice population is, as you've already mentioned, and it depends on a whole host of other things. It depends on what your local hospital's like. It depends on whether health share is completely crap and how, you're dealing with everything yourself. Oh, did I say that out loud? So, all these factors that will determine it. So we've got to be careful with targets. But on the other hand, if we never set ourselves any kind of target, then we've got nothing to work towards. So I would argue that, the reason we go for SMART aims is to balance the sort of the sort of woolliness of no target with the dangers of sort of unintended consequences from targets or from getting it wrong, choosing the wrong target. And what you will often find in quality improvement projects is you set a target, you realize it's either unattainable or actually it's too easy and you've achieved it, and you say, well, okay, so are we going to now set a harder target, or are we going to say, right, we fixed that problem, we move on to the next one? And there isn't a right answer. Okay. Let me just hang on, I've lost the chat box. The mistake of being still logged in the surgery is you get urgent screen messages come up in front of your slides. You can't see what you're doing. So what else do we have? So I think these were all pretty good, actually. So Henry, in your answer, you investigate possible reasons for high MSK referral rates. Really good point. So this is, to me, this is about the baselining. So that's probably not the aim in itself, but it is a really key point. If we don't know what's going on and why, then it's very hard to fix it. Okay. So can we identify unnecessary referrals and reduce those? So that would be an aim. Your aim statement might say, reduce unnecessary referrals by X% by when. A word of caution. I've heard lots and lots of aim statements that say, inappropriate referrals, inappropriate appointments. Define. Really difficult to define that. Okay, so just not saying it's a bad thing. We all kind of, let's be honest, we all get a bit frustrated by some of the stuff that comes to us, but how do you define that? And if you can't measure it, you're going to be very hard to improve it. So that's just a Davita. Targets can be quite political. Yeah, absolutely. Targets are almost always political, whether they start political or not. Most of the targets that we're given that we have to meet they start out political. There's some politician who wants to get a quick win that they can use to get re-elected. Rachel, very good point. Stifle excellence. People meet the target and don't exceed. So absolutely, if you say 80% is enough and I'm getting 81%, I'm delighted. Well, why don't I want to get 85% or 88% or 100%? So these things are, it comes down to sort of defining what's good, and that can be very difficult. And Zoe, learning can come even when targets not met. Yeah, absolutely. I mean, the heart of quality improvement, I think we sometimes forget this, is that we're trying to learn all the way. So if any of you are interested, there's a great book about sort of startup culture called The Lean Startup, and so lean is sort of one part of quality improvement methodology. What I'm describing to you is not entirely lean methodology, but it's sort of related. Lean comes out of manufacturing, particularly car manufacturing, and the idea is sort of all about being absolutely free of waste and super efficient. It doesn't always work perfectly for healthcare, not for all healthcare anyway, and certainly not for all of general practice. But the lean startup is really interesting because the guy in that book, the guy who writes that book, whose name I've forgotten, his argument is when you're starting a company, your currency is not profit or income or anything, or a patient, customer satisfaction, anything, those things. It's learning. It's how fast can you learn. So you're trying to go through incredibly rapid improvement cycles to get as much learning as you can as quickly as possible, because when you start a new business, and this is talking about things that are kind of completely fresh, you don't know if it's going to work. You don't know if anyone's going to buy it. So you have to just cycle and cycle and cycle as fast as you can. So learning, absolutely key thing, okay? And the learning may be, this is not a problem. We don't need to do this. We can just relax, go back to doing something else, okay? And Rachel, your point about we're trying to make something that's measurable and it might not accurately reflect what you're really interested in is a very good point, and it can be very difficult. And when we come back to measurement later, we'll talk about this sort of balance you've got between a measure that is sort of easy to get or to collect versus a measure that's really meaningful but might be really expensive to collect in terms of the resource that's required or the effort that's required by people. So yeah, all excellent points. Well done. Fantastic. So you got these answers, didn't you? What is the best? How are you going to measure it anyway? When are we going to do it? So that's not really an aim statement at all, frankly. And this one, so do we know our baseline? So reduce is a bit woolly. So reduce by what? By how much? Is it really a problem? Do we know that? And we've got the solution in the aim, which is an absolute classic mistake. So I'm just going to add on 2 questions that I'm going to suggest to you are really, really useful when you're writing an aim statement. So most quality improvement projects, so certainly I'm guessing for you guys, you're going to be coming up with something on your own. Okay, you might do it in conjunction with other people, you do a bit of engagement, but at the end of the day, you'll probably be writing this aim statement yourself. Ask yourself, and this is just classic coaching techniques really. So how achievable is it? Okay, if it's less than 7 out of 10 achievability, you might want to reconsider, unless you can think of ways to make it more achievable. It goes back to the SMART, A is achievable, isn't it? So, but it's quite funny how often people write an aim, and when I say to them, so, do you think you can do it? Not really, too difficult. Okay, well, maybe try something you think you can do, because otherwise you'll probably fail. Break it down, do a bit of it. And then the second one, how engaged are you? Now, you could be asking that of a team, okay, but most likely quips are usually driven by one person. And again, because of the culture of requiring people to do quality improvement projects, we quite often see that actually someone is not that interested. They're like, well, yeah, I could do, couldn't I? So if you're not really committed to it, think again, find something else, because you just won't finish it, okay, and you won't get much out of it. So that's just another tip. And just in terms of measurability, so I'm going to come on to measures in a second. So this is sort of getting ahead of myself in a way, but key things, can you think of an outcome that matters? Can you measure the activity? And if so, how are you going to measure it? So you've got to start thinking practicalities, and don't forget that it might be qualitative. So we might well be looking at satisfaction scores, for example. They're still really valid, okay, as long as you can record them easily. So I'm going to now just introduce you to one bit of theory, okay, and then I'm going to give you a little bit of work to do over a prolonged coffee break, okay. So I don't think I talked about this last time, but if I did, then stick your hand up early. Does anyone know, and I'll take this verbal answers because again I'm feeling lonely. So does anyone know of any way of breaking down types of measure? What types of measure can we look for? You may or may not know this, don't worry if you don't.
Do you mean like subjective or objective?
Okay, well, that's an interesting breakdown, and it may be useful to us. So certainly subjective tends to push towards the qualitative, which, as I say, is still important, but there's not quite what I'm looking for. There's a framework. You'll either heard of it or not. I really just wanted to hear a voice, so thanks for talking, Rachel. So I'm going to give you the answer then. That's fine. So key things. So I've already touched on, right, that I mentioned the word outcome. Okay, so the first one is an outcome measure. At the end of the day, if you're making an improvement, if you're doing an improvement project, you want an outcome by definition. Or if you don't, then I think you're in the wrong game. So you want some outcome, and whatever you define that as. Is it reduced musculoskeletal conditions? Is it presentations? Is it, you know, patient satisfaction? Whatever it may be, that's an outcome. But to get to the outcome, we have to do something. Okay, so we have to change something. And one of the classic sort of things that happens is that you make it. So audit is classic for this. Okay, so audit, we make a change, and in 3 months' time or 6 months' time, or when we're about to submit our e-portfolio and we think, oh God, I haven't finished it, we re-audit, and we find things have either got better or they haven't. But usually they haven't got better, or if they did get better, they've probably gone off again because people have forgotten the change. Okay, but how would you know? Well, you'd know because you could do something called a process measure. So process measures are, are we doing what we said we were going to do? So we've made a change. So I don't know, we've introduced a new pathway for X or a new form. You know, is it being used? Okay, so I will I'll share that some more examples in a sec. And then the other measure, and this links into something someone put in the chat box, and I can't remember who it was now. I think it might have been. Has it gone? No, I can't find it. Anyway, someone put in Emma, you put in, is reducing MSK appointments even a good thing? And so this for me is starting to get us towards something called a balancing measure. So we can have positive effects with a change, but we can also have negative effects. Okay, so a balancing measure is where we're in advance of a project, or maybe even during a project, we start to think, hang on a minute, I'm seeing, you know, a problem here. We need to measure this negative unintended consequence. So a classic example would be you try to reduce what we might call trivial appointments for the GP. You think, well, we don't need the GPs to see this stuff, so we're going to get them to do other stuff. You know, we're going to take all those cases and we're going to give them to, I don't know, pharmacist or some sort of minor illness clinic or whatever. What's the knock-on consequence of that? Anyone got an idea? What would be a balancing measure for that change? So all the simple stuff comes off the GP list.
GP average consultation time goes up.
Correct. Or complexity goes up, or however you want to describe it, or GP stress goes up, or so you know, whatever the measure may be. All the complex patients, Emma. Yeah, absolutely. So that's a classic balancing measure. The other classic balancing measure I often use to describe is from the 4-hour wait in A&E. So I'm actually so old that I can remember when that came in, and it was amazing. Actually, it was incredible. It really transformed the experience of going to A&E. But there were some unintended consequences of introducing a 4-hour wait. Anyone got any ideas what they might be?
Once longer wait. The 4-hour, you got delayed for ages.
So is that Sally? Oh, Sally. Yeah. So suddenly, if you breach the 4-hour, you might be 12 hours because suddenly no one cares about you. Absolutely. Yeah. Very good. Emma, you were saying. Go on. Sarah first, then Emma.
Sometimes being worried about the people that are about to breach 4 hours means that you don't do things in like clinical need order, and actually perhaps somebody needs seeing more urgently on a clinical reason.
Yep, great example. Emma, what were you going to say?
The same, that urgent stuff might be done less urgently.
Yeah. So actually, what you see if you look at the data for the 4-hour wait, you get this sort of most people. There's a few people getting seen early, and then suddenly a big spike at 3.5 hours, between 3 hours 30 and 4 hours, and then it dips right down, and then there's a little spike of all the ones that go over 12 hours. So that is an absolute classic. So not proper triage, if you like. Increased investigations, because actually you've got 4 hours, so you just investigate everybody right at the time they come in. Everybody gets bloods, because you don't want to be 2 hours in and then going, oh, I need bloods now, or 3 hours in and needing bloods. Clinical decisions units, so sort of short admissions went up because it was actually less damaging to the hospital's sort of targets to admit people briefly. So they all created clinical indecision units and put everyone in there, and that was just a bit of A&E, frankly. So loads and loads of these things. But so some of these things you could have predicted, you know, and you can look for them. And some of them you might actually not spot until you started, and then you go, oh, look, this is what's happening. We need to start measuring this. Okay, so that's a balancing measure. So I've told you outcome process balancing. Okay, there is another one which is called structure, and it's argued that you don't need it for quality improvement projects. If you're doing large scale projects, you might need to think about structural measures. Those are usually, have we got what we need? Have we got enough staff? Have we got enough kit? Have we got enough space? Those types of things are structural measures, and you might want to measure them. I'm just mentioning it but you won't need it for your projects. Okay, so outcome process balancing. I've said most of this already. It's obvious that it should clearly represent the patient's interests or the service improvement. And here's a few examples. This is glitchy, sorry. So, so the process bit is often where the PDSA comes in. We're testing our process change. We're changing something. Okay. Oops. I've somehow gone backwards there. And so I would say, I summarize this outcome. Are we getting the results we wanted to get? So we've made a change. We've got a target. We've got an aim. Are we getting those results? Process. Oh God, I'm going so many clicks. Are we doing what we said we would do? So we've said we are going to change the way that we do X. We're going to introduce a new pathway, a new form, a new bit of tech. Are we using it? You know, so if you put in a new bit of tech and no one uses it, how will you know? You may not know till months down the line. So can you measure that? Are you getting the clicks, etc.? Get me to all these bloody clicks that I've got. Okay, and is there anything else happening as a result of our changes? And bear in mind, balancing measures can be positive. So you might get more benefit than you thought, or you might not get the outcome, but you might get a really positive balancing measure, and that's still a good thing. Okay, so here's a few more examples. So I will share these slides so that you'll get these examples, but you know, classic sort of things would be sorry, another thing gone up in front of my screen. I can't get rid of it. DNAs is an outcome, yeah, but these, remember, these subjective measures of happiness or well-being, whatever, can be really perfectly valid outcomes. Process measures, as I say, it's the thing that we've changed. So we've got a pharmacist. Do the patients accept the offer? We've got, are we measuring tasks? Well, you know, how many tasks are being allocated? Are we, you know, are we trying to speed up? So what's the time? Measuring time might be a process measure. And then balancing measures, where we sort of touched on this, and I think you've given me great examples already, but complaints is a classic one, you know, increased complexity we mentioned already. Or possibly, you know, supposing you put in a new service and then the patients keep coming back anyway to see, you say, well, I spoke to the pharmacist and now I'd like to speak to you, doctor. So that would be an unintended consequence. Okay, so let's do this quickly. So we'll have 5 minutes, 4 minutes to do this. You're gonna have to work fast. 3 minutes, one idea each. Okay, so just think of one measure for each. So we're going back to that, reducing MSK presentations to GPs. We're going to pretend that that's a good idea. Don't shoot me. It's just an example. Can you think of an outcome measure, a process measure, and a balancing measure? I appreciate there is an obvious flaw in this question, but you know, if you know, you know. Have a go, stick them in the chat box, 3 minutes, and then we're going to move to a break where I'm going to give you some work to do. Easily done, Fope, don't worry. Okay, stick them in whenever you're ready, guys. Okay, so some really great ones here. So I'm going to struggle to do all of them, and you will need a drink by now, I should think. You've been listening to me for far too long. So let's just pick a couple out. So we have, so Sally, outcome, percentage of pure MSK appointments goes down. Yep. So absolutely, if we there's loads of different outcomes we could be looking at, but absolutely it may well be. And I'm presuming you mean GP pure MSK appointments, so absolutely that makes total sense. Secondly, are the referral pathways being used before being seen by the GP? So yes, how you're going to measure that is an interesting question. So the way you phrased it sounds slightly tricky, but I think what we're basically saying is, you know, whatever alternative. So the reason this question is difficult is because I haven't specified the intervention. You can't create a process measure unless you know what the change that you've made is, because you're asking yourself, are we doing what we said we're going to do? But Sally, you've implied there that there's a new pathway. So let's say it's a physio, maybe it's not. You know, is it being used? So are all those appointments being booked up, for example? Are they being booked appropriately? You know, and then misdiagnosis would be a classic balancing measure for any new pathway, absolutely. Sometimes hard to measure and may not be that frequent, but absolutely would be important to check out. So thanks for those, that's brilliant. So Zoe, you got a similar one. So this is process, allow physio to triage online consults to directly refer to themselves for first appointment. So what you've described there is what I think your intervention is. You're saying, well, if we allowed that, that would be a way of doing it. So your process measure will be how many of those consults that are booked are triaged directly or something like that. So we've said we're going to allow this to happen. Is it happening? Or it might be, you know, are all the slots filled up by the physio or whatever? So are we doing what we said we do? Your balancing measure, yes. So and that's I would say a specific portion. So that's a balancing measure. There might be different reasons why the patients then come back to the GP. It might be that, you know, they're not happy with their MSK care. That's probably less likely, probably. But yes, they may have other problems where normally they'd come and give us 3 things, and of course it's a physio who doesn't want to deal with the other things or isn't trained to do it. So, you know, fair enough. Another balancing there, referral rates to the MSK hub. Yeah, really interesting. So could go up, could go down, but we might want to track it. What else have we got? So FOPA agree with your process, patients being offered suitable alternatives. So the challenge there is to define suitable. So that's slightly subjective. So we always, when we say suitable, avoidable, appropriate, those kind of words get difficult. They're not necessarily wrong, and we might do it, but we have to be clear how we're going to measure it, and that we've got some sort of repetition. Okay. Which actually brings me on to something. Okay, so you're gonna have to bear with me because I'm gonna just bring something up here. 1 second. So I've gone out of sight because I've got my other computer open. I'll be with you 1 sec. So what I want you to do now is just look at this picture and tell me can you see it here? Oh, there we go. Right in the chat box how you would measure that banana. So it's really important. Bananas are really important, okay? They're really good for us. How would you measure it? How would you define that colour, Leslie? Geiger counter. That's the best answer I've ever had for how to measure a banana. Well done, Zubair. That's awesome.
I would measure this banana from the colour because I won't eat black bananas. So this one to me is slightly overripe because I like them when they're just going from green to yellow.
Any of you who've got children? So I saw this hilarious tweet about bananas. I can't remember exactly how they phrased it, but they said that when you've got kids, you've either got no bananas or you've got tons of brown bananas. Because what happens is you buy a load of bananas and they eat them and you go, oh, they really love bananas. And then you buy a load more bananas and then they don't eat them and they all go off. And it's either one or the other. They either eat them all in about 30 seconds or they leave them and they go wrong. But there you go. Our freezer is full of slightly overripe bananas to make banana cake because that happens. Anyway, so peel it first, of course. My child would measure it if based on sticker or no sticker. Interesting. Oh, I see, whether it's got the sticker on it. Okay, I like that. That's interesting. I haven't had that one before either. So I did have a, so Agnieszka, you have put length and size. So tell me, how would you measure the length of that banana? Sorry to put you on the spot, but it's a really good one, this.
Yeah, that's a good question. Yes, probably measuring tape. Yeah, I would dwell about it. Shall I peel it before measuring or leave it with the skin? Yeah.
Can you flatten it out, or that's
Yeah,
a recipe for disaster, I think. Okay, so interestingly, Hannah, yes, you can freeze bananas, but take them out of the skins first, because it's much easier then to put them in the banana cake. Lesson learned the hard way. So so Agnieszka, yeah, really interesting. So one of the things, so when we do this exercise for real, okay, back in the day, when I used to do workshops in real life with real people, we used to take a load of plastic bananas that were all exactly the same size, and we used to get everybody to write, give them a string and a ruler, which obviously pushes them towards thinking about length or circumference or whatever, and then we'd get them all to write a measure and measure their banana, and then give their written description to the person on the next table and see whether they got the same reading. And often it could be way out, and people would write really weird stuff that was really hard to interpret. So here's a few points about this. Okay, so the first thing is, philosophically, what is a banana? Okay, no, not really. Well, it is sort of, because actually, what is a banana? Is it about, no one's mentioned calorie content, which might actually be quite important. We've had volume, we've had weight, we've had radioactivity, which is, I love. We've got color, very, very important actually. Color, we're not going to eat it if it's brown, so that's really important. So why are we measuring it in the first place? Okay, but the second point is about reproducibility of the measurement. So if you think about a quality improvement project, okay, so normally we're doing this, well, we're all working in primary care, right? So we'll be doing this in a practice. It's very unlikely that only one person is going to be doing the measuring. If we have lots of different people measuring stuff, how do we know that they're all measuring the same thing in the same way? Because otherwise, so if one person is measuring the banana along the, I don't know if you can see my cursor, along the sort of the short axis, and other people are measuring it on the long axis, then you're getting completely different readings. Now, you might say, well, it doesn't really matter because they'll be within enough of a sort of range, but how do you know? So you have to think these things through, and you might need, when you write your description of what you want people to measure, you might need to test that so that you can actually be sure that you're going to get the same thing every time. So thanks for bearing with me, and huge thanks to Zubair for radioactivity. I'm going to look that up. I didn't know about that. I wonder what the variation in radioactivity between bananas is. So whose idea was that? Someone said something really interesting that made me, in the chat box, that made me think. Can't find it now. Anyway, yes, so we're going to have a break.
1,000 bananas to 1 chest X-ray worth of radiation.
Say that again.
1,000 bananas is 1 chest X-rays worth of radiation.
1,000 bananas.
50,000.
5,000. 50,000. 50,000. Okay. So as long as you don't work in a banana factory, you're all right. That's very interesting, though. What do you have to do with the bananas? Anyway, so that's the best. Honestly, none of you remember anything I've said today, but you'll all remember that. So we're going to have a break. I'm just going to quickly stick in the chat box a worksheet for you. Okay, so we're going to take now I think we're going to take about a 25-minute break, which I hope we'll have plenty of time for you to. You don't need to finish the worksheet. We've got some questions about measurement. Okay, so those of you who were here last time have sort of had the intro to this sort of theory. So I'm going to duck out of sight again and just try to put this document in the chat box. 1 sec. But yeah, so this is to sort of see whether you can remember anything, and also there's a bit of sort of just logic in it about, does it make sense to you? So it's like classic sort of traps that you can fall into. So let's just go to the chat box. If I'd been organised and not been doing this late last night, then I would have obviously sent it out in advance, but You can't have everything in life. Let me try cutting and pasting it. Isn't there normally an attachment box in the Teams chat?
I can't see that. You should be able to cut and paste a link.
Okay, tell you what, everyone go and have a drink and a break and walk around and do whatever you need to do. We will find a way to get this worksheet into the chat box within the next 10 minutes, and we're going to meet again at 3 to 4, okay, when we'll just run through some of those questions. So if you don't get them all done, don't worry, but it's a way to get you thinking again about the issues with measurement, okay? So if you come back to your computer, once you've had a bit of a rest, and then there'll be some questions in a little, it'll either be a Word document or PDF, whichever one I can link it to, and I will, it will be there for you to have a go at. And I'll be online, so if you've got any questions about it, then you can just ask them into the ether. Okay, have a good break. Mary, I'm gonna see if I can make it work. I don't know why there's no attach button. I don't know if it's because I'm a guest or something.
I'm not seeing an
Yeah,
attach.
I can't see one either, David. Can you try and drag and drop the file and just see where that takes it?
It's a good idea.
Maybe not. But...
Can you send a link on an email to me or anything?
I could do that, yeah.
You can try and pick that up then.
Yeah, it doesn't like me doing it into the chat box for some reason.
Oh, it doesn't.
Right, coming over in a sec, sorry about this.
Okay.
Best laid plans.
Wow. I think we're having to
say the best laid. To be fair, it wasn't the best laid plan because I did change my plan last night. I don't know why I had this sudden sort of feeling that we might have problems with the chat rooms.
Well, I had a similar sort of feeling at about 1 o'clock that the breakout rooms wouldn't work. So we've been on here already trying to get them working. We managed to get the recording working, but not the breakout spaces.
So I just sent it through, Mary. Can you just open it and check that it should be essentially a series of questions and a couple of graphs, essentially.
Waiting for it to arrive at the moment.
Perhaps it's an atmospheric weather issue going on.
Could be.
Zubair's just put instructions in the chat about how to do it, if you can.
Yes, someone's made a suggestion. You can press a Control, Shift, and E. Apparently, that might be able to help.
So that's share content, but that's to stick it up as a presenter, isn't it?
I think so. I'd imagine.
I don't think it shares the document per se.
Still waiting for emails to come through. We had this earlier. Oh, no, there it is. Got the email.
So there's actually, I've just noticed there's a slight problem with that one. Let me just, might send you the Word document instead, because for some reason question 7 has lost its wording for some reason, which is a bit annoying. Yeah, so questions, basically just tell them to ignore question 7 because the wording's dropped off. Like it's too complicated to try and change it now because I have to resave the PDF. Is that all right, Mary?
Okay, I've just put it into the chat box. We've got that far. Now I've got to tell them about question 7.
I can't see it. Oh, I can see it, yeah. No, I can't.
Question 7, wasn't it?
Yeah, just ignore question 7. Well, basically, there's a graph under question 7 that doesn't.
Ah, there it is. It's come through, Mary.
Woohoo! Teamwork.
Just going to see if I can access. Oh, interesting. It says to me, I've just tried to open up the file, says you don't have access to this file.
Oh, because I can open it, but then it's in my.
If you click on the highlighted blue, it comes up rather than the box itself.
Ah, right, yeah. So you've managed to open it, Leslie, okay?
Yes, I've got it open.
Great.
Okay. Yeah, it doesn't.
Sally, is that Sally?
Yeah.
So for me, it says request access.
And what happens if you request access? Do I get something prompting me to say yes?
Have you tried clicking on the blue link rather than the? Yeah.
They just love Teams.
What's so weird about Teams is that it works one time and then it doesn't work the next time. It's just so.
Did you see the added bit that Zubair wrote, that he said if you go onto the share contact but then look below, it allows you to upload a document?
What does it say?
Well, I think that's actually. I don't think that's uploading, but I think that just puts it up on the screen, but I could be wrong. Let's have a go. You could be right, actually. Let's have a go. It doesn't like PDFs by the sound of it.
We're all trying it now, aren't we? One way or another. Yeah, it doesn't like PDFs.
Mary, could you try forwarding it to me as well, so I can try post it and see if that makes a difference?
Okie doke.
I can try and do it as a Word document. Hang on.
Okay, I forwarded it on to bob.fellowship, Miriam.
Okay.
Still won't show it. What's going on? Seems to only work for PowerPoint. This is the only option it gives me. So you've sent it to
I sent it to Miriam, who's signed in as Bob, as we like to know him.
It hasn't come through yet. I'm just waiting for the email to come through.
Okay.
So is there anything else we can do at this point? I can stick it up as a share screen.
That's very odd. No, nothing's come through.
How do I move that? I can't crop the screen, so I can't get rid of the.
Yeah, because it's expecting it to be a presentation, isn't it?
I
wonder if I can do that. Thought about this.
Right. Well, for those with good eyesight and a big screen, that might work.
I guess also if you photograph the page, then you can zoom in onto your photograph, and then you might be able to see the writing for those of us that are quite blind.
You can actually zoom in on your own screen. So I just managed to zoom in. But I've got a Mac, and you know when you on the touchpad, when you zoom in, it manages to come up closer.
Yeah, I'm doing the same. So if you just scroll with the mouse and the control button over this, then it will go in, and it's just about in focus. Fope, what the other alternative is to look at your screen and then zoom into your screen. So I've stuck it up as a shared doc with the 6 questions. You may not get through all of them, but you can sort of scroll, use your mouse to kind of zoom in. Should help.
That's interesting.
I think we're all trying to play with things in the background here.
I think I've just managed to share that. Could you check the chat and see if you can access it? No, it's not. No. I've just shared it again, Mary. I think it's working now. Emma's just said it works.
Okay, let me get it into the chat. Yeah, that looks like it works. It looks like people have got to it now.
Okay, good. Okay, you're going to get a cup of tea, Mary?
Yeah, in a minute. I've just done, I've got into that as well now, but I just need to know that everybody else can really. Like, worst case, I've got it as a PowerPoint now, the 6 questions. So I can share it on the screen.
No, Zoe can't get into it.
Okay, let's see what I can share this. I've actually put the questions up there. That helps at all.
Okay. Will that move through, Mary, on a slideshow on its own?
Oh, don't know. I don't.
And you don't have to sit with it.
I could put it into slideshow mode, but I would have to step it through, I think. Yeah, I had to step it through, unfortunately. Should be a way that I can do this though.
Yeah, that one's slideshow, does that?
Should be able to step it through automatically. It's a way of doing the timing between the slides, isn't it?
Mm.
I think you might be set up slideshow.
Ooh.
Loop continuously. I think that might work.
So we just go. What happens?
It should just go in a loop.
I'm waiting for it to change now on its own. Oh, no, I did that.
Oh, okay.
It's all excited then, Mary.
I lost my mouse and I clicked it, so unfortunately for that. I don't know what the rest of the buttons do. I can't get out of it now.
Click escape. Did it come up with more options when you did that? Using timings if prevent automatically. Automatic. When you click, does it give any? Oh.
We haven't put any timings in, that's why.
I don't know how we put timings in.
How many people can't open it? Because we can just carry on. If people are back and not able to, I don't want to, you know, have everyone twiddling their thumbs.
I'll unshare just for a minute so that we can all see each other.
I'm back, but I can't open it, unfortunately.
I still can't open it.
Okay, so it's better if I share then, really.
So answer do the first couple of questions, and then I'll quickly run through the sort of potential answers. There's no perfect answer to any of these things, but and then we will move on. So I'll give you about 3 or 4 minutes just to have a look at these quickly.
That's the first question. If anybody wants me to move on to the second question, let me know. Anybody ready for the second question?
Yeah.
Anybody let me know if you want to see the third question. Shall I move on to the third question?
Yeah.
Anybody ready for question number 4?
I've got a few people in the chat saying yes.
Please.
Oh, sorry, I can't see the chat. I'm sharing my screen, so I've lost that ability.
I think I've figured it out in terms of the timing. You have to go into transition and it gives you the time to loop.
Okay. Right, I'll move on to question number 5. We've only got 6 questions, so.
Okay.
Last question then. Do you want to come back to you, David?
Sounds good.
Okay.
So if we actually, no, tell you what, do you mind going back to, let's quickly go through them.
Okay.
I will send out a sort of answer sheet so that you can do this at leisure and you go back through the questions if you want. Anyone who wasn't here can have a go at them. So someone shout out, what are your thoughts here? What's happened? What are you going to do? Don't all shout at once because I'll be deafened.
There's been a jump, about a 30-ish% increase from January to February, but there's not a lot of information to say why that is, what type of referrals. So
loads of questions. Yeah. What do you think the CCG would say? Someone else be the CCG. If you can do it in a CCG voice, then you get extra points.
Well, the CCG would be like, why has this happened? What are you doing?
What are you doing? And what would the partners say?
It's your fault. No.
That's the locum's fault. You want a locum? Okay, so what's the problem that we're sort of seeing here? So my answer to this question is we don't know what's happened, which is kind of what you were saying, Fopo. We don't really know. Why not?
Because we
So someone said need more information. Tell me more.
Well, we need a breakdown of, it's not been running long enough, so you don't know whether everybody fell over on the ice in February compared to January. You don't know if it's a trend.
Correct. So essentially we've got 2 data points, and 2 data points is never enough. If you've got 2 data points, unless they're exactly the same, one will always be bigger than the other. Okay, so the key question for us is what's been happening until now and what happens next? And frankly, can we pull these out into, smaller data points, essentially more, pull them apart into weekly or daily even data points so that we can see this trend more clearly. So exactly right. And the CCG would say, oh, it's gone up, you've done something wrong. Incorrect. And so the danger here is that you overreact to the natural variation of a system. Things go up and down all the time. And if when we draw our graph, what we see is that, a range of between 100 and 140 is seen consistently, then that's natural variation. And if we overreact to it and start trying to search out what's happened, we'll go mad because there's no cause. It's just natural variation. Okay, can we have the second one? Well said, Sally. Very good. Well done, Fope. Excellent answer. Okay, so what's happened here? Has the project helped?
Well, it looks like it has, but there's nothing to compare it to what the demand's usually like in those months.
Okay, very good point. So we don't, the answer to yours is we don't know. Okay, so initially we kind of go, oh, it looks pretty good, doesn't it? You know, wait time's gone down, but is there natural seasonal variation anyway? Okay, does anyone remember what I said about averages last time? I probably did say this because I say it a lot. So averages are inherently misleading. Okay, so if you imagine 10 data points from 1 to 10, from 10 to 1 and 5.5 repeatedly, they all give you the same average. So a line that goes like that, a line that goes like that, and a line that goes like that give you the same average. So average is so dangerous. Okay, so when you get the answers to this question, you'll see 3 different examples of how that data could have been created. Averages are misleading. Pull the data out, look at it as frequently as you possibly can, weekly, daily. Monthly is better than 6 monthly for sure, because you're looking for patterns. Okay, you need seasonal variation, as you mentioned already. I think it was Emma, you said that. So yeah, absolutely disaggregate your data. Next slide. What's happening in this data?
Every 5th is higher. So it looks, if that was Monday to Sunday. Yeah, so it looks like the Fridays are busier, but we don't have that data. Which day of the week is that?
So every 5th data point is higher. So we're going to assume that something is happening to this data point. So that's good. How easy was it to tell?
It stands out actually. If you can't, it is a pattern. There is a pattern.
You're obviously good with numbers. Point being, so okay, you can see it. When you see the graph, I can't show it to you now because I haven't got it into a slide deck, but the graph is much easier because it goes like that, you know, everyone. So the only point here is draw a line chart, draw a run chart, a line graph, whatever you want to call it. You'll see it immediately, the pattern. Okay, but you're absolutely right, Agnieszka. You win. Your eyes are attuned to this stuff. Okay, number 4. Thank you, Mary. What do we see? It's not a trick.
Looks like something changed about 2/3 of the way through this time. But the second half is all Fridays and the first half is random days. So I guess it probably says that Fridays after some point of possible change, hard to know, are fairly consistent, but it's very hard to see what the pattern is because the days that are chosen seem to be fairly spurious. So it's hard to know what's caused any sort of variation that might be present, and are these. I
don't know what the hell is. I've only just noticed that those letters are down there. That should be just numbers. So apologies for that. Yeah, I don't know how that happened. You know, that's very weird. So essentially, ignore that lot. Okay. So unfortunately, I've given you a difficult task. I have to rewrite this. What are you seeing? Just in terms of look at the patterns, there's 2 different things. So you've mentioned at the right-hand side, 2/3 of the way, something seems to have changed. Yeah. What happens about 1/3 of the way in?
The amount of variation changes.
Yeah, exactly right. So this is why run charts are so valuable, because they can tell us about variation and they can tell us about median or mean, usually median we use. So what we've seen here is that something has happened about 1/3 of the way through to stabilize our system. We're getting less variation. That's usually a good thing. Okay, a stable system is easier to fix. It's, you know, if you imagine, so what we know is that all those readings there are all natural variation, but some people are waiting 35 days and some people are waiting 7 days. Well, is that acceptable to you? You know, open question, maybe it is. But actually, generally speaking, a stable system with less variation is a good thing. So in that scenario, our first change that we made was say we've got to stabilize this. We've got to somehow create less variation in our system because it's not fair, it's not safe. You know, if you're waiting 37 days, anything could be happening. So that's the first thing you do, is try and squish these things together. And then you can see again, as you said, Emma, that 2/3 of the way through, there's another change. Something's happened, and it's the median has gone down. So presumably there has been a change made, and you know, one would hope, but there may be another reason. Could be that something else has happened. It's unlikely, looking at that is random. There's almost certainly something has happened. Are you getting a lot of background noise of baby noises? Because I've got my window open. No, okay, good. I haven't got a baby myself. I'm past that. Too old. Number 5, please. Okay, what do you see on this one? This one's a little bit harder to see.
It looks relatively stable apart from these two
data points. So it's a high one and a low one, yeah?
Yeah.
Yeah, so that's exactly right. So if we actually plotted what are called control limits on this chart, we'd have 2 red lines which would contain almost all of the readings, but not the high one and not the low one. And that tells us that those are something called special cause variation. Something has probably happened during those weeks. And if we wanted to, we could then look into why that had happened. So the reason, again, why run charts are so powerful is because you can immediately see that. And you might want to ask yourself the question, well, what's going on? And you might not. You might say, well, actually, you know, it's only one off. So even within the statistics of a run chart, there's still, you know, maybe a 1% chance that a reading like that, Christmas week, fewer referrals, yeah, good idea, Sarah, could well be. Even a one-off reading could still be random. Okay, so if you think about the sort of the power of sort of random statistics, like outliers are still possible, you know, but they're much less likely. And the statistical validity that we use with SPC charts, so statistical process control, is about 1.4% chance that an outlier, either up or down, is random. So it's a very high statistical probability that those are outliers and something has changed. But you might still not be able to find out what's changed. You might not be able to work it out. Okay, last slide. Right. Any thoughts? Did anyone get onto this one? It might have been you didn't have enough time.
You need to measure demand against time going home over several months, because you're always going to get a duty that takes longer but has less patients in it. How much the pharmacist has used and what for, and how many can be diverted to her on over a couple of months.
Yeah, so you've just told me an outcome measure and you've told me a process measure. Anyone got a balancing measure?
Departure time on non-duty days.
Interesting, yeah, could well be. Yeah.
So you might push work onto non-duty days in order to leave more promptly on duty days, potentially.
Absolutely. Pharmacist happiness, you know. It might be that some of the work comes back, so you know things get pushed on and then come in the next day. So that, as you said, that might be a reason for going home later again. So essentially, it's just emphasising what we talked about before. You're looking for a mixture of measures for most projects. Okay, one measure is probably not going to cut it, so you need to have a process measure. Are we doing what we said we're going to do? Is the pharmacist full? Outcome measure: are we getting home earlier? Are we happier? Are we doing bath time? You know, whatever it may be. And then the balancing measures. You may not use balancing measures, but you need to be aware of them and just be thinking all the time: is something going wrong? Is something going wrong? Is something going wrong? Okay, so very good. So judging by the people who answered the questions, you get this stuff, so that's excellent. if you didn't answer the questions and you've got questions, or even if you did answer questions, you've got questions about it, now's the time to ask. So how did that all make sense? Okay, any questions? I'm going to just change slide decks. So what I want you to do after today is to, when you're thinking about your projects, obviously we've talked about aim setting, so have another go at writing an aim statement, make sure that you've not stuck the solution in there, make sure that it's pretty smart. If you get stuck and you want to test it with me, then you're very welcome to email me afterwards. I'm very boring, I like this stuff. And then I want you to have a think about measures as well. So can you think of a process measure? Can you think of an outcome measure? Can you think of a balancing measure? Okay, now, let me see if I can get my laptop to share this one. So I'm going to just introduce you. So we've got about just over half an hour. And I want to just introduce you to something, some creativity techniques. So these are sort of augmentary, really. They're sort of things that you can sort of use to be more creative, essentially, to broaden your thinking, okay, to not get trapped into narrow ways of thinking. And I'm going to send you out afterwards a booklet, if I can. I think I can still find it online. It's a legacy document from years ago, which will sort of summarize this stuff. And I'm going to go through it quite fast, and we're going to have a couple of goes at using them, and I'm going to do that using Menti, which is a last minute change to make up for the fact we haven't got any breakout rooms. So thinking differently, so it's what it says is essentially, by applying structure, we can be more creative in the way we think, okay, and we can avoid the traps that are there within our brains, essentially. So human brain is designed to think in certain ways, and we have sort of, you know, a predisposition to do that. So we can sort of get outside of that paradigm. Now, a brief story. So I once had some career coaching, and I was talking to my coach about how much I love this sort of stuff, creative thinking, and she said, "Oh, you should meet one of my other coachees. I'll see if he's up for it, because he's a real creative and he's always talking about creativity, and I think you'd really get on." Anyway, so we met up for a coffee, and then met this guy, and we started talking. He started telling me some stuff, and he said, "So, you know, why are you interested in creativity?" And I said, you know, "Oh, well, you know, I do this improvement work and we use these sort of tools." And after about 30 seconds, he just went, "Oh, you're not creative. You're not creative at all." And it was hilarious. Oh, am I not? Okay. And his view of creativity was this sort of almost like a Zen-like thing of sort of meditation, and he used to wake up early, set his alarm, and then just allow himself to drift in and out of consciousness. And then at the end of that, he might have one word or a color, and that would be, anyway, you can imagine he worked in marketing, and that doesn't really work for me. Okay, but I will just flag up. So there's an absolutely superb TED talk called, I think, something like "Why Schools Kill Creativity." It's by a guy called Ken Robinson. You may well have seen it. It's like one of the most watched ever. And Ken Robinson is the guy who you would love to be giving a speech at a wedding you went to, because he's really funny and he's really droll. He's just lovely. He's like the father of the bride. He's wonderful. He sadly died last year, actually, but he's done a few TED talks, but this one is brilliant. And what it says is creativity can be learned. Okay, so it's not something you're born with or not born with. So all those kids who say, "Oh, I'm not creative," you know, we've basically taught them already. You know, so my son won't do art. So I can't do art. I just can't do it. I'm failing. I can't persuade him that actually he could. It's a learned skill. You can be more creative. Anyway, the point here that I'm long-windedly making is that creativity is something that you can work towards. You can increase it, even if you are someone who is not creative and you say, "Look, I just, you know, I like simple processes. I follow the steps." Well, here are some steps that you can follow that will increase your creativity in the context of doing improvement work. Okay, and the document, Thinking Differently, which is a legacy document from something called the NHS Institute for Innovation and Improvement, which has been abolished a good 10 years, since about 6 months after I started working for it. I try not to blame myself. So it's a great document, and it's all described exactly how you use them. Okay, so banged on a bit there, isn't I? Sorry. So it's all about ideas. You've probably heard of De Bono. So De Bono died just about a month ago, I think. Edward De Bono. You may have heard of him. You may not have done. He talks about, or he's an expert in thinking. He was not a man burdened by self-doubt. If you look up some of his quotes about how amazing he is, he really thought he was pretty amazing. But he has some very good ideas. One of his tools we're coming to in a minute. One of his ideas is, I think, very analogous to the sort of way we think about, CBT and these sort of ingrained thoughts that we have, and sort of maintenance cycles and all of this. He talked about streams of thinking. I said, we essentially, our brain is full of valleys. We think in certain ways. There's lots of factors that define that. The key factor for us in this context is that we all work in healthcare. Okay, so we all think a little bit alike, whether we like it or not. Some of us think very alike, and in fact, I've done lots and lots and lots of workshops over the years with lots of people working in primary care, and it's really interesting because they say the same things that the guys down the road say, and that the guys in the other part of the country say, up north, down south. Very similar thinking patterns. Okay, you get a different group of people together, they'll think in different ways. But there's lots of other factors that determine our streams of thinking. Okay, and if you want to change them, there's two ways. You can either randomly, and this is just by luck, you'll just have an idea that comes from a different valley, or De Bono talks about creating purposeful channels. Okay, so we're trying to find a different way of thinking. And that's what this is about. This is about saying, let's diversify our thinking. Let's get into some different valleys and see what we find. Okay, so it's an analogy, or a metaphor, but it might be useful to think like that. And again, interestingly, so I think this quote is quite sort of sums it up really. We're all quite good at innovative thinking, but actually we're blocked by our sort of existing thinking. We're blocked by our mental models of the world. And actually, it's that classic thing, that'll never work. That'll never work. Okay, so how do we create a sort of blank canvas mentally that we can play with? And we're all guilty of this. Okay, and there's loads of other stuff about thinking. If you've ever read Kahneman's work on thinking fast and slow, the fast thinking is really seductive. It uses less energy. The brain wants to do that. So we just make assumptions all the time. Anyway. So, and this is what we're talking about. So I'm just going to skip that one for a second. I'll come back to that. So creative thinking is a skill and everyone can use and improve it. Okay, so I'm now going to try to just flip into Menti. I'm going to duck out of sight for a second, slightly bizarrely. And actually, before I do that, let me just talk about this slide. So this is a summary of the thinking differently process. Okay, so there's two types of thinking: divergent thinking, convergent thinking. With divergent, we're trying to sort of spread our thinking and be creative and get more and more and more and more ideas, and then at some point you have to converge and decide on stuff. So convergent stuff is right, that's what we're going to work on. Okay, so you go broad to get more and more ideas, then somehow you've got to filter those ideas. And what they talk about is these 3 steps. Stop before you start. So that is going divergent to work out what the problem you're trying to solve is. So this links in very well to the model for improvement. So what do we actually want to think creatively about? Okay, now we're not going to go into that today, but there are various different tools that they use to try to define the problem in a way that we can really work on it. Okay, and you get down to this thing, what we want to think creatively about, WWTTCA, which is really, you can imagine, very catchy and has really caught on. And then once you've got that, you then go, right, let's go, as broad as we can. Let's get as many ideas as possible. So if you remember that brainstorming that we did last time, the ideas generation, I probably said something to you at the start, like, try to write down everything, write down the stupid ideas, because they might be the best idea. Okay, so really go as broad as you can, don't filter. Okay, and this in this orange slide here, so sorry, it's probably a bit small, isn't it? Let me just stick it on slideshow. So I'm not going under the desk, by the way. I've just got a laptop down and I'm standing up. So the orange line there, generate ideas. Those are different tools. I'm going to talk you through 2 of them very briefly to get more ideas. So the simplest one, okay, for me anyway, is fresh eyes. I really love this. So if you've just done an ideas generation exercise and it didn't go very well and you haven't got many post-its and you think I'm a bit stuck here, or if you think this group is going to struggle with this because they're really quiet and they don't like writing stuff, you know, fresh eyes says give everybody a new perspective. So you basically create a load of cards or even post-it notes, and you just randomly allocate people to different perspectives. So it might be that you say, right, you know, Emma, you're going to be an 80-year-old gentleman with mild dementia. We might say, I can't remember everyone who's in the session. There was a Henry, wasn't there? Henry, or you're going to be a young single mother with 3 small children, all you know, under the age of 5. We might say to Fope, you're going to be the head of customer service for a large multinational. We might say, you know, Zora, you're going to be an astronaut or an alien come from outer space that you've never seen the humans before. So you can go as broad as you like. You can really vary it. You might say that, you know, someone's going to be the head of product innovation for Google or something. And what happens is you put these people into a different persona and you'll find that they come up with different ideas, and they also quite often come up with a lot more ideas. It's incredibly easy to use. It's also easy to use for yourself. So if you're ever stuck and think, I don't know what to do here, put yourself into a different perspective and see if it works. Okay, so fresh eyes are really simple. I'm going to talk to you about breaking the rules. A little bit harder this one, or yeah, it is a bit harder. I think it's a bit harder to manage a group through it, but I like it. So I'm going to just flip into, well, actually, let's go. So this is what it says, okay. So rules in this context is not laws, okay. Rules are the things that maintain the status quo. They are it's often unwritten rules. Some of them might be written down and some of them might not. When you do this exercise, what you discover is a hell of a lot of the rules that we work with are unwritten. Okay, they're actually just the way it's done. And when you see those, you can go, well, why do we do it like that? Why don't we do something different? Why don't we do half of our stuff online and do all our meetings on Teams, or, you know, whatever? So so innovation is then explicitly breaking that rule. Where will our imagination take us if we do that? So let me just change my screen a second, because I'm going to move you into Menti for this one. So it's a different Menti to the previous one. Apologies for that. And go at the top. Now, I need to change, hang on a sec, to come out of that, go into, right, so the Menti code, Menti's got so popular now that it's got 8-digit codes, 4674 5336. And all I want you to do is to give me what you think of our unwritten rules. Well, actually, there might be written rules as well. Any rules, I'll say. Any rules about the giving of vaccinations. And you can write as many, hopefully I've allowed you to write as many as possible. I think you might be on, you can write whole like lists, or you can, I think you'll be able to write again if you submit one, he says, hopefully. Anyone who's submitted, are you still able to submit? Hoping,
No.
Yeah. Oh, bugger. Hang on. I'm going to keep writing. I'm going to come out and see if I can edit it at the same time. Possibly can't. Right. Try now. Change the rule, but whether it works midstream, I don't know. Oh, I like that one. Be nice to the patient. So I'm going to prompt you. So what other unwritten rules about vaccinations, such as who, where, when, those types of questions? Oh, bugger. There we go. Okay, so we've got some in the chat box as well. Doctors shouldn't give injections. So that's what I was told, because apparently we're too chatty and we can't be efficient enough, which I think was a direct comment about myself and one of the partners here. It's probably true, actually. No, you can't give the vaccine. Stick to consent. Okay, so we've got some good ones here. So let's have a look at these. I'm just going to. So are there any of these rules here that we could break? So let's talk about, so correct vaccination for correct patient. What do you think? Probably not one we can break, I think, unless we want to lose our GMC license. Checking allergies, probably quite important. Be nice to the patient. That's an interesting one, isn't it? What would be the benefit of not being nice to them? It depends where that thought process takes us. If we stop being nice to the patient, would there be any potential benefits? Maybe we'd be quicker. We might be able to get to twice as many because we're not stopping to chat or whatever. Okay. Consent. So supposing we actually said we're not going to consent patients, is that going to be acceptable? Anyone want to argue in favour?
It's only acceptable until something goes wrong and then you're a bit up the creek.
Yeah. So what about, if we said, okay, well, we're not going to take consent, and then someone said, well, hang on a minute, you've got to take consent. We might stop and think, well, hang on, how are we taking consent? So it might be about, so consent is taken by a medical professional. Implicit consent, showing the arm. What about someone who's wearing a vest?
They've turned up the vaccine centre. So in some countries, if you turn up, that's consent. Yeah,
interesting. We do a lot of forms here, don't we? I love that, Emma. Too complicated for doctors to give vaccines. Absolutely. So Amy, good point. Yeah, implicit consent. So so we might then explore the consent. We might explore who does the consent. We might explore, can it be done automatically? Can it be, do they, if they just sign a form that they've read it? And then where does that take us? So what about people who can't read or don't speak English? So there are a load of issues, but it's about getting our thinking further on. Okay, so let's just move down a bit further. So nurses in primary care. So there's two different things there: given by nurses or given in a clinical setting. Yeah, okay. So supposing we say, right, it doesn't have to be a nurse. Also, we're going to challenge that thinking. That's an unwritten rule given by nurses. Where would that take us? Could take us anywhere, you know.
We let male partners give female partners, typically that way round, fertility drugs, which are IM injections. So those people, is there any reason they can't vaccinate?
Yeah, okay, so doctors could do it, yeah. And we might think, well, actually, that's putting into the hands of our more expensive professionals. So, you know.
Oh no, I meant the general public. So if you're having fertility treatment, you're taught to do an IM injection.
You said male partners, and I was thinking, like, I did actually wonder why the senior partners in your practice were giving why the male partners were giving female partners fertility injections. Is this, you know, what's the maternity-based cover in your practice? Anyway, okay, well, let's not go there. I get you now. Very, very good point. Yes, exactly. So exactly. Who, you know, why not? Who could do this? Like fragment injections. Who we could teach people to do that? So actually, what's it all about? So challenging question. What about primary care? What about you know, who is where does it have to be? Does it have to be in a clinical setting or not? Can it be outside? You know, I know some vaccines have been done outside. So interestingly, we did this training module with a doctor called Fazana Hussain, who some of you might have heard of. So she was GP of the Year last year. And she's quite high profile, and she's one of the NHS. You remember there were these big posters in, I think, Piccadilly Circus on these massive billboards of NHS sort of heroes. And anyway, she's amazing, Fazana. She's absolutely amazing. So she saw this slide deck, which I'm just going to stick back up. Give me a second. And we did this scenario with her. And it wasn't that much longer before she ended up on the news because I can't make it go into slideshow. Why not? There we go. So this is how you might draw this out. So, you know, patients arrive to be seen, break the rules. They don't come to the GP surgery. So where does that take us? What's the idea that comes out of it? We didn't really do that because we haven't got the time. So, but there'd be multiple ideas potentially. If you break a rule, what ideas do you come up with? So you have these 3 columns. Okay, what's the unwritten rule? If you rewrite that as a broken rule? What does it say? How do you write that? Where does it take you? What ideas? Okay, so you can have a look at these afterwards. But here's a classic. So this slide set. This is in America, drive-through flu shots. And if we showed this to, you know, around the country many times, and people would go, oh no, you can't do that. Like, where's the patient going to wait for their anaphylaxis check? And what, you know, no, it's not safe. You can't just do it through the eye. It's not hygienic. And anyway, Fazana Hussain sat there, and, you know, maybe a year and a half later, I think it was COVID. No, it was kid vaccines. It was child vaccines in the pandemic. They started doing them in their car park, and the parents could wheel them in or drive them in, and they would do the vaccines outside so that they could keep going when surgeries were essentially being told, don't bring people into the surgery. So I'm not saying it wasn't totally her idea from, you know, it was already been happening in the States, but she took massive, where we go, what's this? Man, jab, bus, like, what's that then, Emma?
Oh, so they took a bus to the Latitude Festival called the Pfizer Chiefs and just started vaccinating young people at Latitude on this bus.
I've literally just got back from Latitude. It was amazing. I've probably got COVID, but I feel fine at the moment. And also we're on screen, so it doesn't matter. Even if I cough on you, it'd be fine. I didn't see that though. That's great. I love it. The Pfizer Chiefs. Actually, the Kaiser Chiefs weren't that great. No, they were good. They were good. So, good point, Amy. Yeah. So sometimes you have to think these things through, but better one jab than no jabs. So anyway, point is that it's that breaking the rules is a way of getting you towards some really sort of left field stuff. Second order thinking. Yeah. Okay. So have I got my slide? So do you remember I showed you that that slide at the start that went like that, like that, like that, like that. So the divergent thinking. So breaking the rules is one of the techniques that you can use to go divergent and get as many different ideas as possible. Okay. Somehow you've got to get back down and narrow it down. So, and that's, you know, they call it like the innovation funnel sometimes, you know, or harvesting. But at some point, you're going to have to think a bit harder about these things. Now, you probably can't afford to think really, really hard about 100 ideas, and you may well have 100 ideas if you've involved quite a few people in it. So somehow you've got to quickly scan them and get down to maybe 10 that you can think about really hard. A really good way to do that is the prioritization matrix that we talked about last time. I mean, obviously, sticking 100 post-its on the wall is it's not no work, but it will get you to the point of having a certain number in the top right corner, and you can then start to look at those in more detail, if that makes sense. So that's one harvesting way. There are others in the booklet when I send it out to you. Okay, just do it. And I'm going to talk to you now about 6 thinking hats, which is a way of, if I could skip back a bit, you probably apply 6 thinking hats to a handful of ideas. 5 at most, probably. It's quite quick, actually. It can be long or short, depending on how much time you've got available. Has anyone come across this before? Anyone want to tell me of an experience using it? I can't see all your faces, so I have no idea whether anyone's saying yes, they've seen it before. Okay, so in time management, tell me, Agnieszka.
That was the idea in, but we can apply to time management, how to prioritize the things, to put different hats on to manage our schedules. So that's how I heard of 6 thinking hats.
Well,
yeah.
So interesting. So I don't quite know the context you mean, but for me, so 6 thinking hats, basically, what De Bono said was there are 6 types of thinking that are the majority of all thinking. And what tends to happen is that we do it a bit jumbled up. So we're doing all of it at the same time. And if you think about a group of people, they will all be metaphorically wearing a different hat at the same time. So if I'm in my, wearing my emotional hat, so I'm sort of just my gut instinct is taking me somewhere, and someone else is being really objective, I'm probably going to have difficulty engaging with them, or I might well do. If someone is feeling very cautious and someone else is feeling very optimistic, they're essentially pulling in different directions. And what that does is it takes up energy. So it's hard work. It means that you can't move forward as quickly. And usually a lot of that energy is wasted because you just end up disagreeing. So what De Bono is basically saying with this model is align your thinking. So do your thinking at the same time. So if everybody is being optimistic at the same time, it's much, much quicker. Okay, and you get much less kind of dissonance. Okay, and then you move on to the next one, and then the next one, and then the next one. And there's a whole book about it. Hands up. I haven't read it, sorry. But I know people who have. Apparently it's very good. So one of the things that he talks about is that you can use these hats in different orders depending on what you want to do. Okay, so if you're creating an advertising campaign, it would be different to if you're, I don't know, I'll think of something else. So fundamentally, what do you want to achieve? You run the hats in different orders. Okay, but fundamentally, the point of this idea is that you get people aligned in their thinking. Now, it's important to mention, if I've left this slide in, no, I haven't. Okay, so you can do this. So some people react to this model. They think it's trivial. They think it's babyish because it's got hats. I have seen people bring coloured hats to workshops. Some people love it. Other people absolutely hate it. Okay, so it may be that you just use language to ask people questions that are aligned to these hats. So yellow would be, what do you like? Black would be, what do you dislike? Objective would be, what questions do you have? Creative would be, what else are you thinking? The emotional would be, the red would be, what's your gut instinct? The processy blue one would be, what do we need to do next? So simple questions. And so if you feel uncomfortable with it, I suspect that you've probably used these questions before with groups and just not really called it that. So a classic bit of feedback is, you know, what did you like? What did you dislike? What more information do you need? Well, that's 3 of the thinking hats. So I'm going to try to prove to you in the last 6 minutes that we can use these really, really fast. Now it's going to be slightly flawed because we're doing it in Menti and you've got to type really fast on your phones. Who's got an idea? Has anyone got an idea for a change that they want to test out using this? Otherwise, we're going to use the drive-through vaccines. If you've got an idea, speak now. This is your chance. Okay, drive-through vaccines it is. So back into Menti. Let me just unshare. So I've done the blue hat first time. So I've decided that we're going to do this through Menti. We're going to do it for literally 1 minute per hat, and we're going to do it in the order that I've specified. Okay, it's not absolutely essential that you do it in any specific order. As I said, there's variation, but I've chosen an order for you. And so we're going to crack on and do that now. So that's the blue hat. The blue hat is thinking about the thinking. It's about the process. It's about getting things in the right order. And okay, so we're going to start. This is drive-through vaccinations. Yellow hat. What do you like? We've got 1 minute. I bet I haven't ticked the box to say you can do more than 1 at a time. While you're typing, I'm going to do that for all of them. Sorry. Okay, so it's all good. Okay, so great. Yeah, easier for siblings. That's the thought. I hadn't had that thought. Really good. Oh, sorry. Less likely to try and get a clinical query, like that one. Yeah, patients likely to talk less. Very good. Maybe if we get them to wear a mask as well. Okay, very good. Avoids problems with venue space. You can do it anywhere in theory, can't you? Okay, so let's move on to the black hat. Now, just a quick word about black hat. Okay, so this has been, some people feel uncomfortable that the black hat is negative, and they worried that you know, there might be some sort of racial overtone or undertone even, and it's worth outing this thought. Okay, De Bono said it's not like that at all. The black hat is potentially the most useful hat of all because it's caution. It's about being sensible, thinking things through in advance, thinking of those balancing measures. So it's actually almost his preferred hat. Not that he's got a favorite, of course, and he's dead anyway. But so just to be aware of that, okay, and I'll just out it in case anyone's thinking, oh, I'm not sure about this. Right, so black hat. What worries you about the idea of drive-through vaccinations? Go. 1 minute, I'm timing. Oh, done it again, sorry. So some great answers here, and you know, again, I've got a touch screen here, and it's every time I try and scroll up because I've somehow not clicked the button for scrolling up. Not very green, yeah, really interesting. Okay, so some really great sort of cautious thoughts there. Okay, so next one. What further information do you need? This is the white hat. Okay, this is about detail and making sure we've, you know, got it set. So what else do you need to know before we might think about doing this? Go. Some really great questions here. Is it legal is quite a good question to ask, by the way, about most things before you do them. Okay, so I'm going to stop you there. So very good. So this is great. I mean, look at the quality of these questions is absolutely brilliant. And, you know, a lot of it's about practicalities. So like, you know, classic blue sky thinking, oh, we could do it. Let's just do it. Well, if you just do it without thinking it through, then what you'll find is you create a massive tailback and the police come down, or the police come down because it's illegal, or because you haven't got a permit, or it pours the rain, everybody's really miserable. Timing, how long is it going to take? How are we going to know? Well, the answer to that is PDSA. Try it. Get someone to come down in the car and pretend you're doing it and see what happens. Yeah, pilot study. Interesting question. Can you access bit of child you need from car seat? Great question. Yeah. Okay, so fantastic. So we've got so much information there so quickly. Let's move on. So green hat, what else? What else comes to mind? What could we do with this? What could we build on it? Is there anything else? Go. Okay, so this is brilliant. So this is, I think this is a harder question very often. Sometimes it bubbles over. It depends a little bit on the context. But some really interesting thoughts here. I'm just going to go. Screen messages blocking my screen. Okay, so yeah, I mean, love it, brilliant. So could we do more than vaccines? You know, what about advertising? What about other things as well? Greener ways, yeah, I really like that. Really good point. Hiring another venue so it doesn't interfere. So really useful. So let's move on. So this one's going to be really quick. You've only got 30 seconds. What's your gut instinct? Four to 1 at the moment. 4-4-2, it's getting close. So I haven't given you long. If I gave you a little bit longer, we might be getting some more caveated answers. Yes, but I'd like to know X or Y. But we sort of got those already because we've got our black hat thinking. We've got our whites. What other ideas do we need to think about? So, but But here we've got at least 2 people saying, actually, I'm not happy with this. So we would probably end up still needing to explore it, but we've moved ourselves forward. Okay, so last question, blue hat, what should we do next? So this is about the process. What's the next step? Got 1 minute to do this one. Okay, some great ideas coming through already. Legality, absolutely. I'm not suggesting we do anything illegal or immoral. High vis bibs, can't do anything about those. Okay, so that is literally, we've had no more than a minute for any of those. We've got a lot of thinking. So if I flick back through the slides, I mean, look at all this information we've got, look at all the, so with a, I mean, you've got quite a big group here, admittedly. You can gather so much information so quickly. Okay, it really can be an incredibly powerful tool. And when I send you the link, there's a little bit more information in there. There's also De Bono's book. There's loads of stuff on the internet about thinking hats. Okay, worth a try potentially. Maybe try it on your own first. Have a problem, just play with it before you use it with other people. But I think you've seen that you can be a bit clumsy with it, as I am, and actually you can still get loads of stuff out, and hopefully really, really useful. So I can see Lee's popped up. I'm running out of time. Got to talk fast. So what have we talked about? We've talked about well, improvement generally. Okay. We've talked about the real importance of setting a clear aim, knowing what you're trying to achieve, being aware that there's always a risk with setting targets and not to be too prescriptive about those. We've talked about how to measure, what to measure, like, you know, what is a banana? That's probably the most important question I've asked you all day. We've talked about, well, we've done those questions around, you know, ways to measure and using run charts and how to look at data. And then we've done some stuff around creativity, how to get ourselves out of our mindset, to stop thinking like healthcare professionals, to go broader before we then narrow back down, and how we can use thinking hats to really critique a problem very, very quickly with a group. Okay, and we avoid that kind of, I mean, it's kind of easier because we used Menti, but even if we'd been talking in small groups, you would have found that actually there was a lot less sort of cross purposes than normal, because actually we're all coming down the same channel at the same time. So, and the most important thing you've learned today, 50,000 bananas are the equivalent of a chest x-ray. Don't forget that. Okay, that will be in your next pub quiz. Okay, I'm going to love you and leave you, because I need to give you time to do whatever you need to do. I will stick my email in here. I'm crap at email, but keep trying. If I don't answer the first time, it's not because I'm not interested. So just keep trying. Yes, right, done. Sorry, Lee.
No need to apologise. What an excellent session, David, and I'm sure the thanks will keep on flooding in on the chat. Thanks so much for your time. What an excellent, very encouraging and very helpful as well.
Okay, good luck with your projects, guys. I shall leave you to whatever happens next. See you later.
Thanks. So just in the last 5 minutes, if you just click onto the new ideas board for David's session, please could you start putting down some ideas for questions 1 and 2. So David ended with a really good summary of all the things that you've covered in the last 3 hours or so. Maybe just pick 1 or 2 things which resonated with you in terms of what you individually found helpful, interesting, or thought-provoking. And the second question, as usual, any intended actions as leading on from today. If you just spend a couple minutes putting that in. a lot of things to choose from.
We have also got another very quick Mentimeter question for you. I don't know if Miriam is there and able to take control and share it.
I am. I'll just share my screen.
You may need to request control because I'm still seeing David's slides here.
Right. Let me know if you can see the slides.
Yeah, got that. If you can post up just a couple of words about how you're feeling after this session about your project, the piece of work you're going to undertake.
That's great. Keep the post-it notes and the feedback flowing. We do feed this back to the speakers as well, so it's really helpful for them with their sessions to get this information.
If somebody is still feeling overwhelmed, do remember that, you know, the team are here and we're happy to help with things, and you've got your mentor as well who can help. So just talking about things sometimes helps to organise it a bit more in your mind. Excuse me.
Just for question 2 of the ideas board, just think about a simple next step, perhaps after listening to David's session and working through those practical exercises as well. 1 or 2 small parts to achievable parts of your projects. That's what I'd like to see putting down in question 2, and it takes a bit of mental energy to really think and commit to that next step, but I encourage you to do that. That's great, and there's something about looking into the resources, perhaps the TED Talks in a bit more detail, trying 1 or 2 of the models or tools which David's given examples of, which is great. For those newer in the second group, just starting to thrash out and thinking about the project, and that part about actually setting out the aim statement, I think is key to that.
Can I ask, with the second group, when are we supposed to start doing a project? Because obviously we're sort of 6 months behind, and I don't know when the new people join. Are we sort of joining them, or are we staying?
No, you're quite right, Sarah. You're going to be joining the new group when they start in September, and then about March or so we'll start talking to you about your year 2 project, because you'll be then falling into that sort of, you know, starting of year 2 and where how you want to go forward. You are doing some of the CPD sessions back to front, so you've done some of the sort of second part of the programme before you now going on to do the first part. But it should all knit together and it should all make sense. But don't worry, if you need to ask questions or you need support, just let us know.
I think that might be why, you know, I'm one of the ones that put uncertain. I think, you know, because we just started general practice as well. I think it's whereas in 6 months' time we'll be in a different position in practice as well. So I guess it's looking over the next sort of few months and trying to start getting a project aim in place.
Yeah, you may end up in a better position than the guys who started last October, because you may have had a little bit more time to think about it. So hopefully it will help you.
Good. So we're approaching 5 o'clock now. Certainly the ideas board link remains live, so you can refer back to it and add to it once you've had a bit more time to think about it. That's all from my end. Mary, do you have anything else to add?
I think we actually have. Do we have one more question, Miriam?
We do.
I hope this will be a very quick one. Is there anything else that you would have liked to cover today? Nobody's typing anything and everybody's very quiet, so that's either a very good sign or we're all ready to go and get our next cup of tea.
I closed Menti down after the last one, so.
But if you wanted to put anything into the chat room or anything like that as well, then we can. Project ideas, yes, we did send out on the invite some sort of ideas, but that's another thing that people might want to talk through with us. Don't forget you've got Leslie and Kathy supporting you as well, and you've got your mentors, so you can always talk to them about potential ideas as well. Probably the big thing is going to be talking to your colleagues in practice, getting their buy-in and engaging, as they say. Okay, no, good points. All of this is helping us to learn, and we should see improvements in our presentations as we go forward, as we're learning more of the things that we could do better. Thank you. Is there anything else from anybody? No? I think at that point then we'll let you all go and get some supper.
Thanks everyone. Thanks for all your input, and it's good to see all your contributions as well. It made today's session even